and we are going to we are going to discuss two topics. One is intravenous fluid, and the other one is parental nutrition. Okay, so now we stick with the we go with the first topic, that is intravenous fluid. Okay, so why do we know why do we want to know about the intravenous fluids? So now you might need to now it's better if it is a discussion rather than I am going ahead with the lecture. Just reading this one, it's better to discuss these things. Okay, so uh, why do you want to learn about the intravenous fluid? Ramai, why do you want to learn about the intravenous fluids? No answers. Okay, fine. So I might have to go ahead there, right? Okay. So now if you go to a ward, if you go to a medical ward, if you go to a surgical ward, you may have seen most of the patients, they are getting some form of IV fluid. Okay. So maybe normal saline, maybe dextrose, and you will see. So they are on IV fluids, but sometimes they use this normal saline or dextrose for various reasons. Example is dilution of drugs. Okay. So and because now one is now other thing is that 70 50 60 to 70% of our body weight is water. Okay, so now because of that, you now if you look at this picture, that you can see total 70 if the body weight is 70 kilos, so out from that 70 kilos, 60% of the body is water. So now most of the water is in the intracellular space. Two-thirds is intracellular space, and the rest is in the extracellular space. So that you can see the you can see now if the body composition is like that, you have to know. And if you give various type of fluid, where do these fluid move? Are they going to stay in the intravascular compartment? Are they going to move out? How fast they move out? In medical conditions, in certain medical condition, how do you give fluids? And so, and what are the type of fluids you are going to use? So you have to know, right? So now I will give you now three examples. Three. Now I will give you now this three case scenarios. Now think about these case scenarios. Now first one is there's a 75 years old patient with high fever, and he complains of loin pain for 5 days duration, and he is tachypnic. His respiratory rate is around 28. You can see the blood pressure is around 80, and he is confused. And a UFR showed feel full pulses. And the second one, so this is the first case. If you are in the surgical ward, if you are in the medical ward, you might get these type of patients. Second one, if you are the medical officer in the pediatric ward, you might get a child like this, 5 years old girl, and body weight is 10 kilos, and the vomiting and diarrhea for about 5 days, and child is irritable, and mother says that she didn't pass urine for she didn't pass any urine for last 3 hours, and urine color was dark when she noticed that urine color was dark. And then you get another patient like 45 years old coming with the RTA and the trauma, blunt trauma to the right upper abdomen, and you can see his tachycardic and the blood pressure is 70. So and is confused and drowsy. So you are getting these patients, and now most of the time you might not manage these patients alone. You might give a call to the senior, and you might give a call to the senior registrar or consultant. He might ask you to give some fluid. So this patient needs some fluid. Can you give some fluid? Okay. So if he asks that question, and what are the questions you have? What is your thinking process? What do you think? What are the questions you will have? Right. So now this one you might have to answer. What are the questions will go into your now mind? Lama, is this one for you have to answer. Right. So
What are the types of fluid that we can
yes,
give?
good. What are the type of fluids you have to give? Good. What else?
Volume?
Yes. How much fluid you have
How
to
much?
give? Good. What else? Volume, type.
The rates.
How fast you have to give the fluid? Good. What else?
For how long?
How long you are going
Um,
to give the fluid? So is it a short period? So you have to give this fluid for about hours and hours. Okay, good. What else? What else? Few more.
Monitoring the input-output chart of
Yes,
the
monitoring the
patient.
input output chart. That mean do you have to assess how what is the response to your fluid management? Whether it is adequate, whether the patient has improved with the fluid management, whether you need to give more or not. Okay. So what else? Okay, fine. What else? So what can happen if you give too much fluid? Can they develop complications?
Yes, sir.
Yes.
Like,
Okay, fine. So what are you going to learn is that these are your objectives. Now you have mentioned all. So when to give IV fluids? Am I going to start the IV fluids now? So do I have to wait? Okay. What is the type of fluid you are going to give, and how much fluid you have to give, and how fast you have to give these fluids, and how long, and how to monitor the patients on IV fluids, and what are the complications they can develop. So if those patients comes, if you want to think about the fluid management of this patient, you have to answer these questions. Okay, right. Okay, so next one. So now first question you mentioned is the type classification of fluid. What are the type of fluids available for you in your words? Okay, so basically now this is one table I found in the internet, but there are basic classifications of IV fluids. Is there are two type of fluids. One is crystalloid, other one is colloid. Okay, colloid again you can divide into two, and one is a blood and blood production, other one is a semi-synthetic colloids, which I will discuss later. Okay, so now basically there are two types, one is crystalloid, other one is colloid. We will discuss about the crystalloid first. Okay, crystalloids are fluids that now it's now the particles, these solutes, they can freely move across the semi-permeable membrane. But colloid, their particle size is very large. They can't move across the semi-permeable membrane. They are going to remain in the intravascular compartment. So this crystalloid you can divide into three. So there are isotonic crystalloid, hypotonic crystalloid, and hypertonic crystalloids, depending on tonicity. So that tonicity is determined by the osmolarity. So what is the solute concentration of the fluid? Now if you get now you can hear. Can you hear? Am I clear? Yes.
Yes, sir, we can hear.
Fine. Okay. So isotonic is that is tonicity. When you give isotonic fluid doesn't move out or in. So they are going to remain in the single place. So that is those are isotonic fluids. So there are basically three type of now there are several type of isotonic fluid, but there is a difference between this table and this picture. Now you can see that this is the plasma concentration of ionic. Now this is how much, this is the composition of the plasma. You can see the sodium is 140, chlorine 103, we can have potassium, calcium, magnesium, and the bicarbonate. This is plasma. Okay, so now if it isotonic fluid means that tonicity should be equal to the plasma. So now there are three basic isotonic solutions. One is a normal saline, other one is a rigorous lactate, which is available in your ward. Okay, those are two basic isotonic fluids available in your fluid, but you must not have seen this plasma light solutions. You can see the sodium chloride, it is only the sodium and the chlorine, and you can see the ionic composition, it is 154 sodium, chloride in 154. Is it acidic? pH is 5.7 compared to the plasma pH, and the osmolarity is around 308. Okay, but in lactate, in addition to the sodium and chloride, it has potassium and calcium, so and the lactate. So these two solution you must have seen in your word. Okay, in addition to that, you have some other fluids like plasma light. Okay, you may not have seen, but if you look at the ionic composition, it is almost equal to the plasma. So it is 140, chlorine 98, potassium 5, and magnesium 3, and you can see the pH and the osmolarity almost same as plasma. Those are isotonic fluids available in your board. Okay, Okay, so that tonicity is that there will be no fluid movement across the semi-permeable membrane. So those are isotonic fluid. So now in hypertonic fluids, is tonicity is less than the plasma. So now these are half normal saline, and now see half normal saline is a hypertonic solution, and then hypertonic in the hypertonic solutions their tonicity is more than the plasma. 3% sodium chloride, mannitol, or 10% 10% 20% dextrose, those are hypertonic solutions. So if you see this table, you can see what are the hypertonic, what are the, now you can see the 5% dextrose, 5% dextrose in half normal saline, 5% dextrose in normal saline. That was a hypertonic solution. Okay, and then this is these are now half normal saline. It is isotonic. It is 154 millimoles. So in addition to that, these 3%, 5%, 7%, 20% mannitol, those are hypertonic solutions. Understand? So this is how you divide the crystalloid. That is how you divide the crystalloid. Okay. Now, so next one is now what happened to what happened to these crystalloid when you inject? Now we will take it two examples. Now, what physiological changes take place after 1 liter of after infusing 1 liter of 1000 normal saline, and what physiological changes take place after infusing 1 liter 5% dextrose? What happened when you infuse these crystalloid? So that's now where do they go now? So if you look at this table, you can see the how these cations and anions are distributed. You can see sodium is the most abundant extracellular anion, and so you can see if you give 1 liter of sodium, what can happen? If you give 1 liter of sodium, it will, now it's how 1 liter of normal saline, it has more sodium, so it will distribute according to the sodium composition of the body. So that's how it's how now this is, if you look at this table, you can see that now most of the sodium is in the extracellular space. Okay, most of the potassium is in the intracellular space. So if you give 1 liter of normal saline, it should remain in the extracellular space. That means when you give 1 liter of normal saline, that this is crystalloid, 1 liter of normal saline, it is now according to that now this extracellular fluid, 1/3 of total body weight, and then now in the plasma 5, and the interstitial space it's 10 liters. So only 1/3 will remain in the intravascular space, and 2/3 will move out to the interstitial space. So you can see that if you 1 liter of crystalloid, uh, now is the no 250 will be in the plasma, and the rest will be in the interstitial space, but not in the intracellular space. So second one is when you give dextrose, what happened to the dextrose? So 5% dextrose, that once dextrose is metabolized, it's pure water. So dextrose will be metabolized, then it is pure water, so that it will follow the water distribution. So this is the distribution of the water. Most of the water is in the intracellular space. That 2/3 is intracellular space, and the rest will be in the extracellular space. So what will happen to what happened to that liter will be, so most of the fluid will move into the intracellular space. Okay, understand? So do you understand up to that point?
Yes, sir.
Okay, so that's what happened when you give crystalloid. So right, so now when you use these crystalloids, that is other question is, when do you use these different type of crystalloid? So now what commonly recommend is that if you can give is that if you can give a crystalloid which is similar to the plasma, so that is a plasma light. So a plasma light solution. So now if you look at this picture, that is plasma light, it is almost similar to the plasma, but problem is that we don't have it now. Cost of the plasma lights, it's very costly, it is not freely available. That's why you don't see plasma light solution in the hospital. But other than that, next what is the next most physiological solution available to us is the lactate. Okay, but even the lactase is not in our setup. You see, most of the time we are using normal saline. So normal saline, these isotonic solutions are used to replace fluid and to maintenance fluids or resuscitation. So these isotonic solutions are used as a first line fluid. Even in children, according to the recent guidelines, previously you must have known for children you have to go for the half normal saline because you are worried about the sodium concentration. But now recent guidelines say even children you have to give better to give isotonic saline provided you monitor the sodium concentration. So you can use this isotonic solution for those purposes. So the 50% dextrose or dextrose based solution. So now now so now okay, forget about. So then you get the hypertonic solution. You can have 3% sodium chloride, 7.5% sodium chloride, or mannitol. You may have seen 3% sodium chloride, but I don't think it's 7.5%, 5% saline is available in our hospital, but mannitol is available. So this can be given in patient with severe hyponatremia. So it's a symptomatic severe hyponatremia. You might see we are using 3% sodium chloride. In addition to that, some head injury patients. So head injury patients, you will see if you go into the neurosurgical ICU, if you are working in a surgical ward or medical ward, patient with head injury and cerebral edema. So we tend to give 3% sodium chloride or mannitol for these patients. So that is, we need to keep the plasma osmolality towards the higher side to absorb the now reduce the cerebral edema. So those are some situation you use these crystalloid. And so remember that now. So crystalloid is always the first line, and whether it is sepsis, whether it is a trauma, whether it is a burn patient, you will see first line is the crystalloid. Okay. Right. So next we will move on to the colloids. So colloid are now, so this is their particle size is larger than the crystalloid. Okay. So they tend to remain in the intravascular compartment longer than the crystalloid. So there are basically two types. So one is some colloid human plasma derivatives, is blood, maybe blood products and human albumin. So some common colloids are semi-synthetic colloids like gelatin, dextran, and starch. So if you look at this table, you can see now albumin, different type of albumin. So the 5% albumin and 25% albumin. So what you see in our ward is a 5% albumin or 20% albumin. You will see if you go to the pediatric ward and surgical ward, you will see 20% and 5% albumin both. And in addition to that, this hetastarch solution you will see. And if you are in the surgical, if you are on the pediatric ward or medical ward, you will see dextran is being used for dengue patients. Okay. So now, so again, so this is a simple graph, and this is another table demonstrate the properties of these colloid. And I can see that you have the 4% albumin, you have the 20% albumin, and it's the molecular weight of albumin is 69. But you can see when you give 5% or 4.5% here, but 5% albumin, this volume to volume. So initial volume expansion is 100%. So that's going to remain in the intravascular compartment for about maybe around 16 hours. But if you give 20% albumin, you can see the expansion of the volume is 250. So if you give 100, because of the increase osmolarity, the fluid will reabsorb into the intravascular compartment. And you can see the dextran 40, dextran 70, and you must have seen now in the most of the time now for the dengue patient they are using dextran 40, and you can see the volume expansion is 200%. Okay. So, and then you have these penta starch preparations, and followed by the gelatin based preparations. So you can see their plasma half life is longer. They are going to remain in the intravascular compartment for a longer duration, but they are not the first line treatment. So these colloids are not given as the first line fluid. So now you can use, because there are some disadvantages of these colloids, and they can lead to anaphylactic reaction. Some colloid, they interact with the cross matching, and they can cause coagulopathy, and the starch solution they can cause acute renal failure. So because of these disadvantages, colloids are not used as the first line treatment. It is Most of the time, it is 95%, it is crystalloid we are using as the first line treatment. Now, so now these are some differences between the crystalloid and the colloid. So now intravascular, now it's how long the fluid is, crystalloid and colloid. Now colloid remain in the intravascular compartment for a longer duration, so hemodynamic effect is longer. And the now so volumes, how much volume is required to maintain the intravascular volume is, it's a colloid, it's maybe around 100 ml. But if you are using crystalloid, you might have large volume to maintain the intravascular volume. Okay, so a risk of tissue edema with crystalloid, you can see when you give too much crystalloid, you might, if you are in a pediatric ward, if you are in a medical ward, you might see periorbital edema. That says that too much fluid, you have given too much fluid. So that's why the periorbital edema, it is obvious. And but colloid, that risk of tissue edema is less. Okay, so enhancement of capillary, now enhancement of capillaries, I don't know what. So that is now so okay. So risk of anaphylaxis low to moderate with colloid. And now colloid oncotic pressure is maintained. So but problem is the cost is more with the colloid. There are a lot of advantage with colloid, but in the with the research, so there are so many research comparing the crystalloid and colloid in various situations, in septic situation, in trauma patient, in burn patient. So there is no mortality benefit. Even though they have these advantages, there are no mortality benefit. Because of that, it's still the crystalloid are the first line treatment. Right. So those are the type of fluid. First question you have to answer is what type of fluid you are going to use in these patient, whether you are going to use crystalloid or colloid. Second one is now how fast you are going to give, how far. Now you somebody said how fast you are going to give, how long you are going to give this fluid. It will depend on your clinical, it will depend on your clinical assessment. Okay, so now these are the clinical features of dehydration, these are the clinical features of severe shock. Okay, so we can see now what are the features of dehydration, what are the features of hypovolemia. So now you have to clinically assess. It is history, it is your examination, and it is the relevant investigation will give you the fluid status of the patient. Now in the first example, it's a 75 years old patient. And now main worry is he is having the fever and feel full of swells, and the blood pressure is low, and the patient is tachycardic. So that is, now you have, now he's the second the girl, the second patient says that it's a 5 years old girl and vomiting and diarrhea for about for few days, and she can't take orally, and she's anuric. So those clinical features suggest hypovolemia. So it is your history is important, and your examination findings and relevant investigations are important to decide where you are. What is the fluid status of the patient? Like say now in dehydration, you will see that your hematocrit will increase, your blood urea will increase. Okay, sometimes your sodium concentration will change. Those investigation will direct you whether this patient is hypovolemic, where how is the volume state. Okay, it's not a single parameter, you have to use multiple parameters and finally decide where you are. Okay, now if you look at this chart, you can see in severe dehydration what clinical parameters you can use. You can use a conscious level. And now if the severely dehydrated child or elderly patient, they will be confused, so they will be irritable. Okay, and they will be tachycardic, and the blood pressure will be low, and the capillary refilling time will be prolonged, and they usually tachypneic. And then now use a reduced urine output for some time. So those features suggest that these patients are these patients are hypovolemic. Okay, so like that, and if you give, and if this is the how you can, now these are the clinical features of dehydration. And then you get these clinical features of shock. There are 4 stages of shock, and you can see more than 40% now. If you think about now 30% blood loss, you can see. So what are the clinical features? Urine output, again respiratory rate, blood pressure, heart rate. So those features, you have to take those features to assess the fluid status of the patient. One, you are assessing the fluid status there. Okay, all right. So now how fast to give, depending on that you decide how much to give. Now now if the patient is severely hypovolemic, so do you want to give fluid over 1 hour, over 2 hours? Now user blood pressure is around 80, heart rate is around 150, irritable, so that means patient is severely dehydrated, so severe hypovolemia, you don't want to spread that fluid over a 2 hour 2 to 3 hours 3 hour period. You might give a bolus at the first. Okay, so you will give 10 ml per kg bolus. You might give a 20 ml per kg to crystalloid bolus and see the response of the patient. So you assess now. Initially, you decide this is the level of dehydration, this is the level of hypovolemia. Depending on that, you decide how you are going to give. Now, if the mild dehydration, patient is conscious and rational, blood pressure is normal, you will not need to give IV fluid. You can start oral fluid rather than giving IV fluid. But in severe shock patient, you have to go for the IV fluid. Okay, so that's now. So now uh, uh, now you assume that we have started fluid. Now we have to decide when to stop, how fast to go. Now still again you use these clinical features to assess the fluid, what is happening to the patient. Now now so you will say now the patient will come if the patient is complaining of the thirst, and now after your fluid resuscitation, patient will say the thirst will improve. Okay, so conscious level will improve. Okay, you will see the patient, initially patient was not talking, now the patient is conscious and he is giving rational answers, and he uses clinical parameters. So what heart rate will come down, your blood pressure will come down, and you will see the capillary refilling time is improving and the respiratory rate is coming down. So especially children, there will be a cold. If you examine the peripheries, you will see periphery in severe shock children or hypovolemic children, you will see peripheries are very cold. With your fluid resuscitation, you will see that peripheries are improving. Okay, so those you are using your clinical parameters. Other one is a urine output. So those your clinical. Okay, so in addition to that, you can use invasive methods too. You can use other now invasive monitoring or non-invasive monitoring to assess the fluid status, which sometimes you may not be able to do in the ward setup. Example, you can use ultrasound scan. So ultrasound scan, what you do in the ICUs, and if you see some registers, they come and use the ultrasound scan to assess the fluid status. They use the IVC assessment, that is the diameter of the inferior vena cava, whether it is collapsing, whether it is dilated. So that is one way. It's not straightforward. You have to combine all the clinical parameters to assess the fluid, but that is from that you can say, so this patient is hypovolemic. Okay, so then other invasive methods. So if you come into the ICU or in theaters, you will see we are using central venous pressure, uh, pulmonary artery wedge pressures, LIDCO, and the PICO, so cardiac output monitoring. From that, you can say this is the cardiac output, this is the volume status of the patient, this is the total peripheral resistance. So many parameters can be derived from these monitors. So CVP, it's a single value of central venous pressure will not give you anything, but it is a trend of CVP you use to assess the fluid status of the patient. So now in this picture, I have shown this is called the passive leg raising test. So here you keep the patient at the 45-degree angle, and then you make him flat and raise the foot end to another 45 degrees. So this is called the passive leg raising test. You are giving a reversible fluid bolus. Now you will give a 200 to 300 ml of fluid. That is a reversible fluid bolus, and assess the patient, assess the clinical parameters. You assess, ideally you might have to use the cardiac output monitor. You might have to use the arterial waveform to roughly assess what is happening with the fluid bolus. This is now roughly you can say whether the patient is fluid responsive or not. So with this, after now what as students, as what you can do is, now in ward setup, you might not have arterial lines, you might not have way to monitor the cardiac output. What you can do is you do the passive leg raising test and check the blood pressure before the passive leg raising test. Maybe after 1 minute, check the blood pressure again. and see whether there is a rise in the blood pressure. So from that, roughly you can say whether the patient is fluid responsive or not. But ideal setup, you need an arterial line or cardiac output monitoring to assess the fluid. So you decide the fluid, and you decide the severity of the dehydration, of severity of the hypovolemia, and you give the fluid, and you have decided how fast you are going to give, and then you assess the patient, how responsive the how responsive this patient for the fluid. Okay, so so next one is that now. So now what I wanted to show what I wanted here is there are how you give fluids. So you can give the fluid to a central line, you can give the fluid to the peripheral line. So, and you can see there are these cannulas are color coded. So why they are color coded is a 14 gauge cannula. This is a 24 gauge cannula. So if you want to resuscitate the patient, if you want to give fluid fast, you have to decide which cannula I am going to use, which pen I am going to use. So in a severely dehydrated patient, sometimes you might not be able to cannulate those patients. You might not, if you want to give fluid fast, you might not use a small gauge cannula, 24 gauge cannula. You have to use a larger gauge cannula like 14 gauge or 18 gauge cannula. Okay, so and now this, the way you give the fluid, you can use the bag itself, and so you can come now, if now bag, or you can use in children you can use a burette. And so there are infusion pumps, syringe pumps are there, so get familiar with these equipments when you go to wards. Okay, right. So and now coming back to the question again. So now here, now the first question, sir. 75 years old patient with high fever and loin pain for about 5 days duration, and the respiratory rate is 28. Blood pressure is 80 by 40, and confused, and UFR shows field full of pus cells. So what do you want to do with this patient? So your question is now, what is the now how much volume you have to give, how fast you have to give, and then what is the type of fluid you are going to give, and how do you know the response to your fluid management. So what do you want to do with this patient now? Anybody? So what is the type of fluid you want to give here? Lamai?
Crystalloid, normal, saline, or Hartmann.
So you want to give the type of fluid is crystalloid. Fine. Okay. So how fast you want to give? What do you think about the clinical state of the patient? What do you think about the volume status of the patient?
He's in severe dehydration.
Yeah, so he is hypovolemic. So it may be now we don't have evidence to say higher dehydration, but hypovolemia is there. Pulse rate is around 80, blood pressure is around BP 80, heart rate 80 by 40, and I haven't given the pulse rate here. So we assume that pulse rate is around 140. That is hypovolemia. Okay. So now you know this patient is hypovolemic. And what do you think about the reason? What do you think the reason for this? Low blood pressure.
Septic shock due to
UTI. That is septic shock. So in the septic shock, what happened is that your total peripheral resistance is increase or decrease. It is decrease. So if you know blood pressure is equal to cardiac output into total peripheral resistance, what happened? Your total peripheral resistance drops is your blood pressure drops. So now here it's a relative hypovolemia rather than absolute hypovolemia. There is a relative hypovolemia is there. In addition to that, sepsis causes fluid leak. So leaky capillaries are there. So fluid leak out, as well as there is a relative hypovolemia. So that's why the blood pressure is low here. So now how fast you want to give the fluid here? How fast you want to give the fluid here? Over, what do you think, over 1 hour, over 2 hours, over 24 hours? What do you think? What happens if the blood pressure remains like this for longer duration, maybe around 2 to 3 hours like this? What happened to the organ perfusion? What happened to the renal perfusion? What happened to the cardiac perfusions? Is it good to keep the blood pressure low like this? Yes or no?
No.
No. So what do you want? So you want how many hours you want? How many hours you want to pick up the blood pressure? So you need to pick up the blood pressure quickly as possible. So in the if you go in sepsis guideline, it says that within 1 hour you have to make sure you pick up the blood pressure. Okay, so you need to bring the blood pressure back to normal. So you can give the mean value. So no need, this is your target blood pressure. You want to bring the blood pressures to 100 by 60. You want to blood pressure to 120 by 80. So if this patient is a hypertensive patient, previous blood pressures are around 180 by 100. So it is way below his normal blood pressure. You might need to go pick up the blood pressures to around 140 by 80. Okay, so that your target depend on your history. But according to the sepsis guidelines, your target mean arterial blood pressure should be more than 65. So you try to bring the mean arterial blood pressure to 65 by giving fluid. So you can give fluid boluses. So you can give 10 ml, 20 ml, 30 ml. But in the sepsis guideline, it's recommended is a 30 ml per kg fluid bolus you are going to give and see whether the patient's blood pressure clinical parameters are improving or not. Okay. So can there be complications when you give the fluid normal saline? What do you think about this patient, 75 years old patient? It's not a young patient, it's 75 years old patient. So he may have a lot of comorbidities. You can end up with the volume overload. You can end up with the pulmonary edema. So you have to be careful when you are giving fluid fast here. So you might have to clinic. You will have to closely observe this patient, how this patient is responding to the fluid. Okay, right. So now what about this second patient, 5 years old girl, body weight is 10 kilos, vomiting and diarrhea for about 5 days duration. She is tachycardic and anuric for 3 hours. So what do you think? What do you think about the hydration level? Can you remember that table? What do you think about hydration level, Amai? Is mild dehydration, moderate dehydration, or severe dehydration? Lamai?
Severe dehydration.
It is severe. It is severe dehydration. So you can, if you now, you can see now very tachycardic and very cold peripheries, irritable, so anuric for more than 3 hours. That means severe dehydration. And so severe dehydration means child is going to lose more than 10% of his body weight. Understand? If 10 kilos, losing 10% of body weight is 1 kg. It is equal to 1 liter of fluid deficit is around 1 liter now. Understand, you have the severe dehydration child with the fluid deficit of 1 liter. Okay, so right, so there is a fluid deficit, severe dehydration. And what type of fluid you want to give here? What is the type of fluid you are going to use here? Crystalloid, colloid? What do you want to use? What do you want to use, Lamai?
Again, sir, we can start with the crystalloid.
You are starting with the crystalloid. Okay, now you are either normal saline or either Hartmann. Okay, even though it's child, it's an initial resuscitation, you have to use crystalloid. Okay, right. So and now how fast you want to give? Again, it's a bolus. You have to use 10. You can go maximum 20 ml per kg bolus and see how the child is responding. Okay, you check the heart rate of the child, you check the blood pressure of the child, and you see the capillary refilling of the child and see how the child is responding to your fluid management. Okay, now if it's a 20 ml per kg, how much? 20 ml. 20 ml is 200 ml. Your fluid deficit is how much now? It's 1 liter. So 800 left now. Okay, so now initially you resuscitate the child until now. Initially you resuscitate the child. You want to bring the heart rate down. You want to increase the blood pressure of the child, and you try to you try now that with the fluid resuscitation, that irritability come down. Now the child will settle. Okay, so now after initial resuscitation, 800 ml of deficit still there. So that deficit you have to give over a time. So that you might have to give over 24 hours, like. Okay. So and next case is the 45 years old RTA, blunt trauma to the right upper abdomen, is tachycardic and hypotensive, and he's severe pallor. What do you think? What do you think? What is the reason for hypotension here?
Hemorrhage.
Yeah, that is a hemorrhage. So the blunt trauma to the right upper abdomen. So that is a most likely injury to the liver. That's why the patient is severely pale and the tachycardia and tachypnea. So what is the first line now is again now severely hypovolemic. You need to do something. So you have to give fluid, and you have to give fluid fast. So what is the first line fluid available for you in the ward setup is crystalloid. You will start with the crystalloid, but what do you want? Is it crystalloid, or what do you want here? So you start with the crystalloid, you have to transfuse blood early as possible. Okay, if the cross match now on admission, some most of the time you and the cross match blood is not available. So in these type of situations, sometimes you might have to go for the O negative blood even. So here, in this situation, you have to go for a colloid. Okay, so colloid means you will have to go for blood. Okay, so any questions there? Any questions before I move on to the next one? Any questions? No? Okay, so now parental nutrition. So now what is parental nutrition? Is a nutrition therapy, and now nutrition therapy is either enterally or parentally. You provide nutrition to any patient. So parental nutrition means through a venous access. Enteral nutrition through the parental nutrition through the venous access. Okay. So now why do you want parental nutrition? Is that now not all patients need parental nutrition, and so now so not parental nutrition, adequate nutrition is you need now. So when you and now if you take like example now, so if you go to the ICU, if you go to the surgical ward, even in the medical ward, we know the nutrition is important, and which is you must have done few surgical appointment, and you must have experienced that. Now so how do now this importance of nutrition now if you go if you are in the surgical ward, and sometimes you may have seen some patients are fasting for a longer duration. Now so after the surgery they are not fed for about several days, and now so why we need to improve the nutrition is for the fast recovery, for the better wound healing. Okay, so reduce the ICU stay of these patients and prevent complications after the surgery. So most now so prevention of the sepsis, all these complications can be prevented if you give adequate nutrition to these patients. So nutrition can be given in two ways. One is enteral feeds, other one is a parental feed. So enteral feeding is you can ask the patient to take orally, maybe NG tube or jejunostomy tube. Okay, so nasojejunal tubes or gastrostomy tubes. Those are the ways you can feed enterally, and you can most of the time what you see is intermittent feeding, but you can do the continuous feeds. So drip feeds can be started. If you go to the ICU and there are separate pumps are there, you can feed this patient continuously, but what you see is the intermittent feeding. So nurses go and intermittently feed this patient. So other one is a parental nutrition, which is we are going to discuss, and this is directly we are infusing nutrition into the venous system. You can use central lines or you can use a peripheral lines. So and most common method in our setup is we are using central line, but we can use peripheral lines. Now the preparations available for us is aminoplasmin or lipid preparations or dextrose preparations. We can't give to a peripheral line because of their high osmolality. It's called thrombophlebitis. So that's why we are using central line. But specially designed preparations are there. Those can be used to a peripheral line. Okay. So as parental nutrition, what do we give? So we have to give carbohydrate, we have to give fat, and we have to give protein, electrolytes, minerals, vitamins, and immunonutrients, and finally the water. So how these are the things we have to give to a patient, and how do we give, how much to give, and how long we are going to give depend on the patient conditions. Example is that the requirement is depend on your history and your examination findings, what investigations are available. So now example, I see CEO is of this patient, and now what main problem is a dysphagia for they can't swallow. Okay, so they are not taking adequate nutrition. So and their nutrition now that now so now so that in now that's why you have to take the history to assess the nutrition assessment of the patient. And sometimes they have now some patients are coming to the surgical ward with the intestinal pathologies like CA colon, CA cecum. So those bowel obstructions, they can't take nutrition for a longer duration. The post-surgical patients, example, esophagectomy patient and the Whipple surgery patients, they will be kept fasting for a longer duration. So you have to provide nutrition for these patients. So in addition to that, you can use examination, find what is the body weight of the patients, and you can use anthropometric measurements, and so you can use investigations like albumin level, pre-albumin level, or ferritin level, but none of them will give you now those are these albumin, pre-albumin, and ferritin. Those are going to change depending on the patient conditions, and those are acute phase proteins. And now they might change depending on the inflammatory response. Those they will not give you this is this patient nutrition state is adequate or not. So this albumin level, normal albumin doesn't mean that patient's nutrition is adequate. Okay, so and very low albumin, again, that doesn't mean this patient nutrition is inadequate. So that you have to use your history, examination, and all the tests. You have to combine and decide what is the nutritional state of this patient. So now what we are going to give is a calorie. So calorie now you have to calculate how much calorie to give. You have to calculate. So ideal way to calculate the calorie requirement is indirect calorimetry, which we cannot do in our setup. It measures the oxygen consumption and the carbon dioxide removal, which we cannot measure in the ward setup. So then now instead of that, what we are using is we can use predictive equations. Like in the second, you can see this is a Harrit-Benedict equation. You can use body weight of the patient, height of the patient, and you feed those. Now using the formula, you decide this is the calorie requirement for this patient, or you can use the weight-based equation. So this is calorie requirement for this patient is around 30 kilocalories per kg per day. Like that, you can decide this is the calorie requirement for this lesson. So but what we commonly use is this weight-based equation. We decide 30 kilocalories per day for this patient. From this calorie requirement, general rule is 60% should be given by the carbohydrate and 40% should be given by the lipid. So now carbohydrate means 50% dextrose, and the lipid preparations are 20%, and the 10% lipofundin solutions are available. So we use those solutions to provide energy, and the 50% dextrose solution to provide energy as carbohydrate. So that's how you calculate the carbohydrate, and you give the now preparation you are using is the 50% dextrose or lipofundin. So next one is the protein requirement for these patients. Now, again, so general protein requirement is 1.2 to 1.5 grams per kg per day, but this figure can increase depending on the patient condition. Example, in the burn patient, multiple trauma patient, septic patients, their protein requirement is higher than the normal people. So you might have to go up on the protein requirement. Same for the energy calorie requirement. So the calorie requirement will go up in these patients also. So in addition to that, so now I mentioned here that what are the things we have to give. We have to give calorie as a carbohydrate or fat. Then you have to give protein and electrolytes. So these are the electrolyte requirement for this electrolyte requirement. Sodium 1.1 to 2 millimoles per day, potassium 0.5 to 1 millimoles per day, and the calcium, magnesium 0.2, and the potassium 0.4 millimoles. There are ranges, but this is easy to remember. That's why I have put these figures. So those are the electrolyte requirement for this patient. And you have to give vitamins as well as trace elements. Okay? And these immune nutrients. So immunonutrient mean that improve the immune response and modulate the inflammatory response. So sometimes these are available, and now the omega-3 fatty acid, glutamine, and arginine. So these now there are no strong evidence, but there are some evidence these will improve the mortality of the patient. So improve the outcome of these patients when we add these immunonutrients to patients. So in addition to that, like copper and selenium, zinc, those will function as an antioxidant. So now if you are calculating the parental nutrition requirement to a patient, you have to think about how you are going to give energy, how we are going to give protein to this patient, and how we are going to give what vitamins to be added to these patients, and whether the immunonutrients are they available. So are we going to now, if now as example, zinc preparation. So now vitamin solutions are some vitamin solutions like Zincovit. They have large amount of zinc, so you can add those vitamin solution to these patients. If you are giving, sorry, now IV you can't do, but you might have to combine IV and oral both, right? So and now this is a simple TPN calculation for the 70 kilogram patient. Now here what you have to give the energy. Now we I told that it is now we are going arbitrary 20 to 30 kilocalorie weight based energy calculation. Now here energy is a weight based equation. So we have 30 kilocalories per kilogram per day. So 30 kilocalories per kg per day. So 70 into 30, it is 2100 kilocalories. So from that, now in this example, they have calculate 50% from the carbohydrate, and another now they have calculated 50% from the carbohydrate. So that is 1150 kilocalories should be given from the carbohydrate. Here it's the kilocalorie. You have to convert it to gram. So 1 gram of carbohydrate produce 4 kilocalories. So now how many gram of carbohydrate you need to, you have to divide this by 4 kilocalories, and now 4 kilocalories. So then 50% dextrose contain 500 gram. 50% dextrose mean 500 gram of carbohydrate. Dextrose is there in 1000 ml. So that means 1 ml of dextrose equal to 0.5 gram. So simply, so you can calculate how much ml of dextrose should be given to this patient over 24 hours. So now just go through this one, and then you will understand how to calculate the protein and the now this total parental nutrition regime for a 70 kilogram patient. So just go through this one, so then you will understand, right? So, and how do you give this parental nutrition is through the central or peripheral line. And now the preparation available for us to the aminoplasmin, lipofundin, those should be given to a central line, because their osmolarity is very high, and otherwise they are going to cause thrombophlebitis. So but this preparation, which is called the KBVAN, so those are very low osmolarity preparations, less than 850 milliosmol. Those can be given to a peripheral line. So now if you are a house officer in the surgical ward, and you have to decide if you are going to start parental nutrition to the patient, you have to know this patient need a central line. Okay, if you have the peripheral now these preparations, then you can infuse it to a peripheral line. So you have to decide, so I need a central line for this patient to, if I'm starting parental nutrition. So after starting parental nutrition, what do you want to do? So how we are going to monitor these patients? So now again, history. Now you have to decide how long. Now sometimes patient will be on total parental nutrition. Sometimes you might combine parental and enteral nutrition both. So you will start with the parental nutrition, or with gradually you will start enteral nutrition. Then you will stop the parental nutrition. How you are going to start this will depend on you. But during when you are giving nutrition, either parental nutrition or enteral nutrition, you have to monitor this patient for complications. So now there are some investigations you have to do daily, like now ideally you have to check the body weight of the patient, you have to check the blood sugar daily, and you have to check the electrolytes daily, and the full blood count, hemoglobin, those things you have to check daily. But now electrolyte like magnesium and phosphate, you will do them initially, then you will do those investigations less frequently. So you have to decide according to the clinical parameters of the, according to the clinical condition of the patient. And then checking magnesium, calcium, phosphates, that is not that's very costly. Okay, so that's very expensive. And now complications of parental nutrition. So how do you monitor this patient? Next, the complications of the parental nutrition, those could be catheter related problems or metabolic problems. So catheter related problem, when you insert the catheter, you can end up with the bleeding, damage to the vessels, pneumothorax, hemothorax. Those are early complications. Later you can end up with the local sepsis, you can end up with the line related sepsis, venous thrombosis. Those are catheter related problem. You have to now you have to observe. Now assume that you want parental nutrition, you send the patient to theater for the central line insertion. The patient came back after central line insertion. You have to look for these complications. There can be immediate complication and late complication. Sepsis. So sepsis is, line related sepsis is very common in patients who are on parental nutrition. So make sure you you observe this patient for sepsis. Okay? And the other problems with the parenteral nutrition, it can have the volume overload, hyper and hypoglycemia, refeeding syndrome is that. So now malnourished patient, you will start full feeds. Now you go for the full feed rather than starting slowly. You start 30 kilocalories per day, 30 kilocalories per day energy. So what can happen is that they will go into the metabolic syndrome. Their phosphate level will go down, their potassium level will go down, their calcium and magnesium level will go down because of this sudden dextrose load. So that can even end up with the cardiac arrest. So that is called the refeeding syndrome. Because of that, you will have to start very slowly. Now you might have to start with the lowest energy level. So you will start with 15 kilocalories per day, like, okay. So they can have electrolyte imbalances and the liver functions, abnormalities, the liver functions. Now as I mentioned, when you calculate this parenteral nutrition requirement, it will depend. So, and your respiratory failure. So now if you give too much carbohydrate, what happen? So end product of the carbon dioxide is end product of carbohydrate is carbon dioxide. So if the patient is in respiratory failure, patient will struggle to remove the carbon dioxide. So because of that, you might have to give more protein-based parenteral nutrition rather than the carbohydrate-based parenteral nutrition. So in the burns and sepsis, your protein requirement will be high and your energy requirement will be high. Again, same in a trauma patient. So acute pancreatitis patient. So and so in general rule in acute pancreatitis is enteral feeding is always better. If the patient is not vomiting, if the patient tolerate enteral feeding, you will start enteral feeding. But some patients you might have to go for the parenteral nutrition. So then you have to decide. So how you are going to adjust your nutrition requirement. Okay. Renal failure, I think that now, so you have to go for the normal. But acute liver failure, then you might have to reduce the the triglyceride level. So now you might go for the carbohydrate based solutions rather than the lipid based solution. So you have to decide. So how you are going to provide parenteral nutrition for this patient. So now if you go guidelines on nutrition support in ICU, this is now if you go to the website of Sri Lanka College of Anesthesiologists, there are separate guidelines, and you can download this guideline on nutrition support in ICU patient. So but you can use it for ward patients also. Okay. Right. So, and that's about nutrition, parenteral nutrition. When you give parenteral nutrition, how do you calculate the parenteral nutrition? What complication you can develop with parenteral nutrition, and how do you monitor patients on parenteral nutrition? Okay. So that's about two topics. Any questions you have from these topics? Questions, Tinalamai?
The cardiac overload, what we will do, sir?
Any questions? I can't hear.
There is a cardiac overload following IV fluid. How we manage it, sir?
There is a cardiac?
cardiac overload following IV
Okay,
infusion.
cardiac overload following IV fluid. So now, so what you should do is you have to decide whether this patient is now whether there's a fluid overload. Okay, so now in some patients like children and elderly patient with ischemic heart disease, patient with heart failure, so you have to be careful when you are giving fluid. Now in sometimes now in a fluid resuscitation, recommended fluid bolus is 20 ml per kg, but in these type of patient you will not go for 20 ml per kg 20 ml per kg bolus. You might start with the lowest possible bolus. You might give the 5 ml per kg bolus. You might give a 10 ml per kg bolus. Like you will give a 100 ml or 200 ml fluid bolus, and then gradually reassess the patient. Now, assume that 75 years old patient ejection fraction is 30, and you will give around 200 ml fluid bolus. Give another 200 ml fluid bolus. You clinically assess the patient. See whether there are basic capitations. What is happening to the saturation of the patient? Basic capitations of the patient. So you assess that. So if there are basal capitation, that means patient is in a fluid overload. So now you can assess now so one is first. Now your question is how do you manage fluid overload, but before that you have to confirm this patient is in the fluid overload. Okay, so now clinically assess, your clinical parameters are there. Patient will become dyspneic, you might see some periorbital edema, and then you examine the lungs. You will hear some fine basal capitation, not coarse basal capitations, and you will see the patient may be tachypneic. If you do X-ray, you will see now signs of fluid load. Then that situation, if the patient's urine output is good, so if the patient can pass urine output, you might use a diuretic. Okay, you might use a diuretic to offload. You are clear to dilute, remove some fluid. Okay, so that if the patient urine output is good only, but sometimes if they are in acute period, acute renal failure, you might have to go for dialysis, so renal replacement therapies. But what is important is if you assess this patient is hypo now, if you are going for the fluid resuscitation, don't go to that stage. But before that, you have to carefully balance your fluid. Okay. Okay.
Okay.
Any other questions? Any other questions, Naman? So I hope so. Now the first one important thing is intravenous fluid. So now when you see, if you go to the ward, when you say they are giving fluid, think so why this patient is given crystalloid, and why normal saline, why not Hartmann solution, and how fast the fluid is going. Is it a maintenance fluid? Is it resuscitation? Is it resuscitation? Is it maintenance fluid? Why this patient is getting fluid? And so what are the complications? Whether he has developed any complication because of this intravenous fluid. So when you can stop the fluid. So now if the patient is on IV fluid regime, and you can think whether that patient needs fluid. Actually, shall I stop the fluid? Can I oral fluid? Or now oral fluid is always better than IV fluid. So can I start oral fluids? So like that you have to think. Okay. Now, if you see now go to the nursing stations and see what are the type of fluids available, what is the ionic composition, and those things you have to learn when you go to clinical settings. Any other questions? Shall I stop then? Okay. Thank you, Lami.
Thank you.
Thank you.